in the meantime, maybe I could just welcome everyone. Welcome to Doughty Street virtually. My name is Oliver Lewis. I'm a barrister at Doughty Street, and I'm delighted to welcome my very good friend and colleague, Kate Mercer, who is an advocate, and she trains advocates and has a sort of national reach. And so we thought it would be really interesting to have an hour or so, not talking necessarily to our usual audiences, which are lawyers, other barristers, perhaps academics, but really ask advocates on the front line what's going on, and to share some of our experience as well. So maybe you could, Kate, move to the next slide. Have we done introductions? Anything you want to say, Kate?
No, other than very excited to be here with you, Oliver. And yeah, so our background's advocacy, by which we mean the non-legal advocacy. So it's the advocacy in health and social care. And our role is supporting the sector. So we're not an advocacy training provider, but we work a lot with people who are advocates. So yeah.
So we're both a bit webinared out, to be honest. So rather than have, you know, one person talking to a load of PowerPoint slides overpopulated with text for 20 minutes and then hand over to someone else and then leave 5 minutes questions at the end, we thought we'd try and be as interactive as possible. And so we'd really like your help and support in doing that. So we're going to ask you some questions. This will be quite interesting. We'll also share the results with you as we go along, and we might tweet about the results later on. But we'd like to know who you are. So I'm going to launch this poll, and so if everyone can click on one of those things that you can hopefully see on your screen, we can figure out who you are and who we're talking to. Goodness, amazing. This is so exciting.
Wow.
Right, wow, so 201 advocates, 6 health and social care professionals, 23 lawyers, ooh, that's scary for me, and 11 other. Wonder who you are. Maybe in the chat you can reveal yourselves. Okay, brilliant, very interesting. I'm gonna end the poll there. Everyone should have voted already. Share results. There you go. Right, let's move on. I think we advertised a load of bullet points of topics that we would discuss. And what we've done is clustered those into 7 themes, which we're going to go through. We're not going to spend the same time on each of these themes, but we thought that these are certainly themes that the advocates who we've been in touch with are dealing with. You might want to do full screen there.
Sorry, I'm just trying to get the chat. I can't see the chat.
Ah, right, yeah.
If people are okay, right, forgive me.
Yeah, I'm going to put the chat on my second screen. That's a screen management is an issue, right? There we go. Yeah. Okay. So we'd ask you to ask questions in the chat rather than using the Q&A. In fact, you might not even see the Q&A. So just ask any questions or contribute ideas in the chat if that's okay. And we'll try and address those as we go through. Over to you, Kate.
Okay, so I know that I'm talking now to a fairly educated crowd, but just in case for our colleagues across health and social care who perhaps might not be that familiar with advocacy, what we mean by our advocacy is the very traditional speaking up with and for people who are often unheard. And that's the primary goal of an advocate. It's not to make decisions, it's not to mediate or resolve. Advocates will never have a view on what should happen. It's always about pushing for what that person wants. And the kind of frivolous example I often give is if somebody asks me that, you know, tells me that they want to live on the moon with 6 pink elephants, well, that's what I'm fighting for. That's, you know, even though it's not going to happen and ridiculous, that is exactly what I'm fighting for. So that's the kind of the core of the advocacy. But we also have this kind of, the stick that we poke services with kind of alludes to where advocates often get involved when things can go wrong. So when people find it difficult to access a service, or they're unhappy with the service, then that's where an advocate can come in and, you know, kind of help to push for things. I've included the proper definition there from the Advocacy Charter. I won't read it out, but that's kind of the well-established definition of what we mean by advocacy. So hopefully that makes sense. Yeah, I can't access any of the chat, Oliver, so or Richard, can you kind of poke any questions are coming through? I think it's because my screen's on share. But so yeah, so moving on to advocacy in the current context and the current climate of coronavirus. There are a large number of groups of people who are entitled to what we call a statutory advocate, by which we mean the advocacy role has been introduced within a piece of legislation, and it's a legal duty for people to have an advocate. And we wanted to make the very clear point at the beginning that none of the regulations or the changes in law that have come out since the coronavirus pandemic touches advocacy. So that means that it hasn't been reduced or removed. We've heard of instances in mental health settings and in the community where professionals have thought advocacy rights have been reduced. They haven't. If anything, we think that the need and eligibility for advocacy is increased, because a lot of people who would normally have their natural allies around them to help make decisions, well, they might not be as actively involved in their lives in the current crisis. So that would mean that more people, in fact, would have an access to an advocate. And there's just this huge demand at the moment for people to be really mindful that as decisions are being made in this crisis period, that human rights of people are not forgotten about or kind of trampled on. So we really wanted advocates to be bold and brave in continuing to defend people's human rights. That's not to say that we're unreasonable and that we can't help in the crisis, but we are that backstop in human rights defence, along with people like Oliver and lawyers. We're part of that kind of framework. So thinking about that, we wanted to ask you, in a year's time, in 2 years' time, in 10 years' time, when you look back at this crisis, really interested in what you think you're going to be most proud of. So it'd be great to put some things in the chat box, and maybe Oliver, you could.
Yeah, I'll pick out some. We've already, so while you're typing, everyone, someone, J Savage, has said, I'll be most proud of finding ways to keep on raising the voices of my clients, and it's working. So that's good. Someone from, hi, Peter Edwards, lawyer. I'll be most proud of using the law to protect human rights. Someone said innovative use of technology, speaking up for the vulnerable, finding innovative ways to communicate. So for those who can't see the chat, at the bottom of the bar of your screen, there's a thing which looks like a bubble, and it says chat. So if you just click that, the chat box will appear. If you've got two screens, you could drag that onto your second screen, so you can see that. Wow, we're coming in. Just a moment, everyone can.
These are great.
Yeah.
I can see them now.
Okay.
Yeah. Right.
Doing all we can to let people know that we might not be there, but we're still here, and we're going to come on to that in a moment. Lynn Lockwood says, I'm proud of the way our team has stayed calm and focused on supporting the clients in any way they can and have adapted to new technology very quickly. Great. We're going to ask you about your experiences of using technology and doing remote advocacy. The adaptations we've made in communicating with people, says Tricia Hazelton, to have their voices heard. Hopefully some will remain in place in the future. Yeah, so what extent is what we're doing now, is what you're doing now, going to be the new normal? What aspects of that are helpful and can endure? But what aspects aren't working so well, which is what we're going to be asking you in a moment.
Yeah.
Rachel Mason says she's going to be proud of helping overturn a CCG letter not to convey a person with learning disability to hospital. if they get COVID-19. Oh, congratulations, that's very good. Ellie Click says, doing the job every day and speaking to my clients every day. Wow. Building good relationships and maintaining them. Fantastic. And Caroline Screen says, ensuring the response from services is to the individual rather than a blanket response. Yeah, and we'll be covering that That's later critical. On, blanket bans of visiting, things like that. Excellent. Thank you very much, everyone, for your input there. Shall we move on, Kate?
Great, yeah. So we're going to start with the topic, really topical, on whether advocates should visit the person face-to-face. So we know that visiting can mean all kinds. A visit can technically mean a phone call or a video chat. But we wanted to get a sense from our sector, how many people are actually visiting people face-to-face, or are you just doing remote advocacy? So by remote advocacy, we mean at a distance, so not face-to-face. So yeah, so if we can do a quick poll, that would be great. And the first question is, if you're doing remote advocacy, which group of people, for which people do you feel that this is working really well? And then we'll go on to a second question to pick up any themes where it's not working well. But really keen to hear people's experiences again in that chat box. Are you accessing people? Are you able to go into mental health hospitals, for instance, via Zoom or Teams or even WhatsApp? In care homes, is staff helping to facilitate that communication with their advocates?
I can only see the results. I can't actually vote, but are people able to click on more than one of these, or do you only have to select one? That might be a flaw, I'm not sure. Okay.
Yeah, should we close that and publish?
Yeah, so there, yeah. So there we've got a person in a locked mental health setting. It's working well, and residential care home, but working, yeah, let's stop that and maybe launch this one. Where is it not working so well? For which people is remote advocacy you're finding not working very well? One of the things I've picked up, certainly from the cases that I've been doing over the past few weeks, are that judges, so for example, the Vice President of the Court of Protection, Mr. Justice Hayden, has said in guidance and in a case, in a judgment, that, you know, really the expectation is to do virtual, for example, capacity assessments. So one just has to adapt, and there's a recognition that adapting and doing virtual assessments is not as good as face-to-face. We have to work with the resources and the environment that we have. But I've also heard that some people are simply reluctant to do it. I've heard that some trusts, for example, are not even contemplating doing capacity assessments virtually. So I'm really interested to see what you say here. The CQC, for example, also is saying that its default visits are now virtual, and apparently it's going very well. So this is interesting, right? If you look at the results here, what do you make of this, Kate?
So I think in terms of the remote capacity tests, I know advocates have had varying experiences of that, including some advocates who've had been successful in challenging capacity tests, which they feel haven't been done thoroughly enough. One example was an advocate, the person wasn't supported by the staff, so you have this assessor kind of firing questions, and the assessor concluded that they didn't have capacity, but the advocate went in and said, actually, and they used that second principle in the MCA about practical support being given to the person, to successfully kind of challenge that, and they did. I think there's a few of us that are a bit cynical about the kind of direction of travel with LPS and the proposals about basing decisions on previous assessments and perhaps making more of a, putting a premium on records rather than seeing the person face to face. Kind of ironically, that this kind of has given us an unplanned test of how that's going to work. So I think it's really clever of advocates and other, anyone involved in supporting people who lack capacity and are dealing with the MCA, is to think now, whilst we're in the thick of it, what that experience is, and does it work actually relying on past assessments, past records, rather than that direct face-to-face contact, because instinctively it feels wrong, that's not going to be good, but intuition's not going to count for much, is it? We're going to need good data and good experiences to kind of look at that future LPS provision. So that's my initial thoughts. In terms of the poll, not surprised at all that the advocates are being most concerned about people who lack capacity. And we've talked, haven't we, Oliver, about the lack of safeguards of people in these settings, that CQC aren't going in, the LGO aren't taking, advocates aren't going in, RPRs aren't going in, and there's real concerns about people's vulnerability and safety. Shall I mention now about the safeguarding very quickly, that there was advocates often raise safeguarding concerns through our work, and there's a service who on average raises about 10-15 safeguarding alerts themselves every month on average, and that can range from people being denied access to services right through to more serious instances of neglect or abuse. And when they looked at their data since March, they'd only referred 2 safeguarding alerts. So they've seen this huge reduction in the safeguarding work that the advocacy service is doing. And again, I think that that's really significant. And for people on the session today, I'd encourage you to think about how we're going to interpret that experience and that data, so that we can use that in the future to push for perhaps stronger advocacy in these sessions, or inform, I'd shout about people's experiences, I think.
So it's just on the chat, Kate, some people are saying it's not working well for any of those groups. Sorry that you could only click one, but it gave us a good sense. Obviously, this is not a scientific poll. Gave us a good sense of what's going on. Someone else has said difficulties in safeguarding situations where the person may live with the person alleged to have caused them harm. Also, that you can't be sure that they aren't being watched or coerced. Yeah, we'll come on to that in a minute. Other people saying, I don't think it works for any groups. Someone else has said the lack of in-person visits strips advocates of some of their independence. We are more reliant on the feedback and cooperation of staff, and we're less able to spot safeguarding issues within homes. That's interesting.
Yes. And if you think about it, it's not just the structural independence, and every advocate will know it's the perception of independence, isn't it? Which is why we don't go into the office and perhaps overly friendly with staff, is because we have to be seen to be on the side of our partner. Now, if our advocacy partner can only contact us through the staff, then it's obvious, isn't it? Then that's going to undermine who we're working for and confidentiality and those things. It's no point kidding, is it, that it's advocacy is normal? It's not.
Maybe if we move on to the next slide, and in the meanwhile, Caroline, thanks for your point, which I think is worth sharing with everyone. You said that those on the autistic spectrum and the ability to engage may actually be less anxiety causing online, but for others that will make engagement with non-verbal cues even more challenging. Yeah, so it really has an impact depending on the individual's communication skills and learning disabilities, autism that they may have. Yeah. Right, I'm going to stop sharing that. And now we're going to look at some bits and pieces of using technology in delivering advocacy.
Yeah, so just some people sharing people's experience, I think, of delivering remote advocacy. And, let's be thoughtful about why we're using technology and how we're going to use it. So, as you guys know, that there's different strands to advocacy. And if your support that day is really about self-advocacy and helping somebody to work out what it is that they want to say, well, then remote technology might be absolutely perfect for that. And a telephone call, an online, video chat, it will be great. I think I don't know how to phrase this, but so just a very quick story of an advocate, an RPR, paid RPR, who called the care home up and kind of how are things, that general question, to which the care home manager, kind of quite proudly announced, oh, everything's great, we're keeping everybody safe, we've locked everyone in their bedrooms. And it was, then that kind of allowed the advocate to have a very gentle but open conversation about, well, actually, that might need to be thought about on an individual basis rather than just locking people up to keep them safe. So this kind of, we can still pick up issues. I think it would be silly of us to think that just because we can't go into these settings that we can't do that check and challenge function that we often have. The more presence we can have, even if it is remote, it still counts for something. So do be encouraged with that. And other advocates have fed back about remote talking to staff has been really positive when checking about conditions on the dolls, which more than likely have not been able to take place, but then having that conversation about alternatives and what's going to happen to support the individual. So if I give you just a couple of two kind of rough examples, one was in a mental health hospital, and the advocate working with that ward managed to identify space on the ward, which was an office that wasn't being used anymore, and they basically turned it into like a conference facility. So the office equipment, they kind of wiped and put on the Zoom and Teams, I think, and then patients could go into that space, not just to talk to the advocate, but they could privately then talk to the advocate, but also to keep in touch with family and friends, which argues probably more important for people in institutional settings. So that was a really good. And if you're working in settings that haven't got that, I would implore people to have that conversation now about what facilities can be used, even if it's mobile facilities, but what can we be doing to do that if you haven't already? And then, this is a really common theme where advocates are making appointments with staff so that they are booking in kind of protected time to go through updates and how that person is in, particularly if they're subject to adult authorisation. And on the whole, advocates, the feedback I'm hearing is that that's working, to be blunt, in the better care homes, and then perhaps not surprisingly in the care homes that people might judge as not so good, the staff are struggling to maintain that contact. But again, that's really important feedback, and just because CQC aren't going into these settings doesn't mean that they don't want to hear from you. And if you're picking up on these things, I would be talking to CQC about any issues that you're facing.
Kate, there's some really interesting contributions on the chat. Let me just pick out a couple. We're going to come on to PPE. Lynn. Jackie says that she was supporting the young man section for the first time, spoke to him through text, calls and video, but the ward didn't have any capability for video, so he had no representation at meetings. An example of a nurse helping a client in a tribunal over Teams and was told to be quiet as she was trying to make the client aware of who was talking and what was happening. Other people saying that they've asked the local authority to consider using safe rooms in their offices for advocates to meet people.
Perfect.
Don't know how that's gone. Some of the wards are using NHS Attend Anywhere, which is the in-house Zoom-like platform that works well, according to one person. Some people have said that they're trying to ensure that advocates feel confident that they can work at their own speed and take breaks when they need. Home working can be exhausting and lonely. Yeah.
Yes, indeed. Yeah.
There we are.
Lovely. Yeah. 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 Look, beautifully captured some of the challenges. Yeah. Yeah. How are you keeping in touch with people, Oliver, from a legal side? Are you using similar platforms?
Yeah. So if I want to have a discussion with an instructing solicitor and maybe the lay client, we would do that by telephone or we usually use Teams for that.
Yeah.
Sometimes Zoom. Court hearings are still going on, albeit virtually or in a remote way. And the NHS platform is being used for mental health tribunals. The Court of Protection, the ones I've been involved with have mostly been on the phone. There's a BT conference call system, or Teams. But I know other colleagues have used other platforms. I think it depends on the judge and what they have on their laptop and what their judge bosses have told them to use.
Yes, yeah. And I think there's, I mean, goodness knows how much guidance has come out of government in the last 6 weeks. It's been phenomenal, hasn't it? But there's guidance for everything. And I did see some guidance on kind of technological platforms. And they were, because there were concerns about GDPR, particularly with perhaps the more informal chats like WhatsApp or House Party. So it's worth checking that guidance out. But yeah, things like WhatsApp can still be, I think particularly for advocates, you know, that can be an option as well. And
it's encrypted. And some solicitors firms, law firms have different rules. One of my instructing solicitors, their firm has been banned from using Zoom because of safety reasons, you know, in terms of speaking with clients or about clients. So look, that's remote visits working well, but what about for people where it's just not possible? And we've already had examples. You've told us of the people that you think it would be most difficult to support remotely, and those were people who lack capacity to give you instructions and people without verbal communication. But someone's just put on the chat, what about people in seclusion, for example? How are you even going to know that there's someone in seclusion? You know, so there are instances where remote visits won't work. So Kate, do you want to speak more to this?
Yeah, and in these sessions, I mean, ironically, that, you know, people in seclusion, people who lack capacity and can't ask for an IMHA particularly, that group of people have long suffered from poor access to advocacy. And what we've been driving at for a number of years is an opt-out system, which is where people automatically get referred unless they say no thanks. So if you've got somebody in segregated seclusion, or, you know, there's concerns about restraint, those people should be getting, if you're operating an opt-out system, they should be coming to you, and you should be known to your service. And it's also worth mentioning the Mental Health Act review, that's one of the recommendations that we're hoping we'll go through. So if you haven't got an opt-out service now with the agreement with the hospital, again, I implore you to really look at that, so that you are getting people, because you don't know who you don't know about. And of course, it's the people who can't ask for an advocate who are arguably in more vulnerable positions and need you the most. But just thinking generally about remote visits won't be suitable for everyone. But just to say, it's a technical barrier because the hospital, you know, some people have mentioned there, they haven't got the equipment. Some care homes didn't have Wi-Fi that was accessible to residents. Those types of things I would be expecting advocates to be pushing hard on and getting fixed quickly, because there's no kind of excuse for that. And the, you know, local authorities and providers, I would be expecting them to be dealing with that. And certainly the guidance is that the more somebody's movements are being restricted to a particular place, the more you would expect adjustments to be made and maintaining contact through other means. So if it's a technical barrier, it's a physical barrier like equipment, you know, just get that sorted. If it's more of an internal barrier because it's communication, or perhaps the person's got an impairment of the mind that makes it very difficult because they don't understand about that type of platform, then you might need to consider visiting the person face to face. And what we would say is that you have to base that on a very individual decision based on the risk to the person, the risk to you, and the risk to other people in that setting. But any blanket bans that an institution has introduced, I would be very, very careful and questioning of, because the decision to visit an individual should be done on an individual basis. And remember that advocates are not visitors. You know, we've had it confirmed from DHSC that you are an essential worker. So you're not a visitor. You are there. If you're an IMHA Care Act, the relevant bits of legislation give you a statutory right to visit people. Now, it's not like a forced entry right. So it can be stopped if there's risk. And if you think about a mental health session, for instance, you might find that there's risk on the ward that means you can't visit that day. So that's okay. But for COVID, I would be asking questions about, is the COVID in the setting now? Does my partner have COVID? Are they at particular risk? And if these are things that that are present, then it'd be less likely for you to go. But there will be some people where you will have to go, and if that's happening, then we will need to talk about PPE. And yeah, I think a lot of advocacy services aren't yet prepared. They haven't quite upskilled to get ready for PPE. Some services have. And then there's questions around who's funding that, because you wouldn't, I don't think, have budgeted for PPE, so you're expecting CCGs to cover the cost of that. But those types of things, I think, are going to come in the next week or two. So let's think about that now. Well, yeah, over to the poll.
Yeah, I'm going to launch this poll. Are you offering face-to-face advocacy? While you're voting, just to chip in on the blanket bans, if I may, Kate. I've been involved now in 2 challenges to blanket bans, and now I'm on my 3rd, which is a blanket ban of a trust, which has banned solicitors from visiting their clients, even clients whose instructions can't be taken remotely. So please seek legal advice if there's a trust or a care home or an entity which has a blanket ban in place and is not letting you in circumstances where you feel that you need to see someone face to face and you have the PPE and it's safe to do so. Right, so that poll, let's have a look. Share the results. That's really interesting.
Yeah.
So lots of advocacy employers have instructed you advocates not to. That's really interesting.
Yeah, and of course there will be a lot of advocates who won't be able to because they're personally shielding, or they live with people where there's particular risk. But yeah, my gut feeling is it's perhaps a bit naive to have a blanket ban on all advocates not visiting. That maybe that's something for us to consider. And I would expect that to come down, particularly as we're coming out of the lockdown, with our clear guidance from the Prime Minister. And
for those 29 people who are doing the face-to-face visits.
Gosh, is that all?
29 out of 300 participants right now. How effective do you feel that those face-to-face visits are?
I'd love to know as well, if the 29, whether they have an access to PPE, or whether there's a care home quite early on, a bit like the mental health hospital converted an office space into like a conference room. This care home converted one of the visitors' room into a very clean space. And you could visit for just very short periods of time, 10-15 minutes, sitting 3-4 meters away, I think.
Yeah. Some people I'm sorry for interrupting. Some people are saying care homes are closed to non-essential visitors, and we are classed as non-essential and are classing our PRs as non-essential. In London, we have to consider public transport to get there.
Yeah.
One colleague was given PPE by a social worker for a Care Act assessment.
Excellent.
NHS psychiatric ward gave PPE access, etc., etc. That's really interesting. By the way, we're going to read all of the chat box contributions afterwards, and I think it'd be really worth writing all this up. Please don't feel that if you're writing something and your message hasn't been read out, it's been ignored. It won't be ignored. Right, Kate, I think we need to move on because it's 38 minutes past, and we're only on the second issue, which is a suspension of. Did you want to introduce this? Go on.
Well, did you want to? I feel like I'm talking a lot. Which, of course, I do.
How do you describe yourself, Kate?
A
gobby scouser.
A swearing scouser.
Swearing scouser, right, yeah. No. So do you want me to cover off this one?
Go on, then. Without
swearing? No. Or doing a scouser accent. Okay, so section 17 of the Mental Health Act is well known. Entitles the responsible clinician, so that's the detaining doctor of the mental health unit, to grant leave, and that can be leave within the grounds, the territory of the mental health unit, or it could be community leave. Community leave could be a couple of hours, it could be a day somewhere, it can be supervised or unsupervised, it can be even overnight. And especially for people detained under the forensic bits of the Mental Health Act, so sections 37, 41, having leave and proving that you, the patient, can be all right on leave is incredibly important in the journey towards being discharged from hospital and discharged from section. And one of the concerns is that I've heard of some trusts, and I think you as well, Kate, that have just said, coronavirus, we're cancelling all Section 17 leave for everyone. So there's been a blanket ban for some trusts. Some trusts are doing it really well. And I think now that we're several weeks into lockdown, we're seeing some of those decisions, those blanket ban decisions, which were put in place in week 1 as a sort of panic. I think we're seeing some reflection and some kind of nuanced decisions and some person-centered decisions being made. So some unraveling of the blanket bans. But we're going to ask you whether you've heard now of Section 17 leave. While you're doing that, just to explain from my perspective as a lawyer, I think it's really alarming because, of course, people are in hospital and their liberty is being denied. They're deprived of their liberty. And that engages Article 5 of the European Convention on Human Rights. And we don't know how long this lockdown and how long the suspension of Section 17 leave is going to last. But if people are not being enabled to go on grounds leave and community leave, it's only going to push back their eventual discharge by that period of time. And worse than that, for some people, it's going to have an effect on their mental health and well-being and potentially their behavior and maybe needing more medication and more restrictive practices. So not only is it going to push their discharge back, it's going to cause a deterioration. So I'm personally really concerned about these blanket bans. All right, we're going to end the poll there, share the results. So of those people who do work in mental health settings, that's really interesting. Over half of you who do work in mental health settings have come across suspension of Section 17 leave. Yeah, well, that's something I would say that advocates can kick up a fuss about and potentially communicate with solicitors about that, because it could be that can be challenged. I've noticed that there's been quite a lack of creative thinking by organisations such as care homes and NHS trusts in thinking creatively, well, okay, we can't do escorted leave, 2 nurses with the patient for 4 hours in the community going to the shops, because you can't go into shops, and people, there's the social distancing. But what can we do instead? What can we do differently to achieve roughly the same result?
Yeah, spot on. Unfortunately, we've got this lovely guidance issued from the Royal College of Psychiatrists themselves, which I would encourage advocates to use if you're particularly concerned about the impact of any reductions in leave on your advocacy partners. And it's clearly saying that it should be on an individual basis, and that's, as Oliver said, RCs should be thinking creatively about what the individual person needs. And I think about even things like going for a drive just to get people off the wards. Is that going to intrinsically put them at a greater risk? But possibly not. Going for a bit of exercise out the grounds, if you look at does anybody know if the health regulations which kept us inside have been rescinded since Boris announced we can all go out now as much as we like? Those health regulations, to my mind, they're the bit of the law that says we can only leave our place where we live unless we've got a reasonable excuse. And I think that before the announcement on Sunday, I think that was something we could use as advocates to argue that, leaving the ward for mental well-being is a reasonable excuse, actually. Yeah.
All right. Shall we move on to the next topic?
Yeah. Sorry, Oliver.
It's a testing topic.
Testing. So do you want to run the polls as... Because I think what we're really interested in hearing is if people in care settings, whether that's care homes and hospitals, are having access to tests. And we're going to look at a second about decision making for people who lack capacity to consent to tests. But yeah, we're interested because we've known since April, haven't we, this massive problem in getting tests to people. So this is what the guidance says, that there's an increase for these groups of people to have tests. And again, as advocates, somebody did ask me the other day whether advocates are entitled to tests. And the answer is yes. You know, as an essential key worker, that yes, you would be classed as part of the key worker cohort that can have a test.
And so, can I just chip in? So are solicitors and barristers representing people in care homes and hospitals? Right, so 67% of you have voted. If you haven't voted, please do so. There's an option for don't know, so you can click that, that's okay. Right, people are still voting. So are people being tested in the care homes you work in? Roughly 33% of people have said yes, 10%, I'm going to end the poll there. 10% have said no. All right, well that's good, because it shows that there is some sort of rollout. So 33, ish.
Yeah.
But interesting that 10% of you versus 33% of you said no. They're not people are not being tested in care homes. All right. And so it follows, what's the role of the advocate in testing?
So let's have a look at...
oh, we got another poll here, though.
Oh, sorry.
Which is, are you supporting people to make decisions about testing?
We've got a clear winner on that one.
Do you want to talk through this just as time is ticking on, Kate?
Sure, yeah. So big questions are being kind of considered at the moment about people who lack capacity to consent to the test, and whether it's an SMT decision. There was some guidance that was quite confusing.
SMT means serious medical treatment, for those who don't know.
Thanks, Oliver.
Acronym spotter.
I know. And when we've looked into it, and we've 39 Essex have produced a really helpful kind of rapid response note, which I put the link there. They're saying that it's a best interest decision. And these are some things, if you're working with people who are accessing tests and can't consent because of capacity, these are some things to think about. So check that there's not being blanket decisions made on a group of people or a cohort of residents. So, you know, they'll all have a test. No, it has to be individual decisions, and it's got to be about individual best interest decisions. And as an advocate, I'd be really going back to that basic, what does the person want? Would they want a test? And if they do, well, then that's what you're going to be pushing. And if they don't, if you feel that the person wouldn't tolerate the test, or it'd be very distressing for them, or, you know, that they would even need some form of restraint, well, in that case, then the process of the test may then become a serious medical treatment decision because of the balance of burdens and benefits, in which case it might need to go to the Court of Protection. And we were talking, weren't we, Oliver, around this Scripple case, where, do you want to pick that up? You'll talk more eloquently than I would.
Oh, no. So, of course, having a test may not be it may be in the person's best interest, but not because it may benefit that person necessarily. Colleagues who wrote the 39 Essex paper, which is a very good paper, referred to the Scripple case, where they needed to test for the poisons and so on. So that's a judgment really, or you can read a summary about that. But best interests don't necessarily mean what's best for that person, what will benefit that person. In the same way that it could be in someone's best interest for an attorney, a financial attorney or deputy, to make a donation to a charity that might not directly benefit the person. So the best interest calculation has to take into account, you know, when the person had capacity, if they, for example, have dementia now, Were they a responsible person? Would they have made this decision to have a test?
And I think it was interesting because that reasonable person kind of was suggesting that as a dutiful citizen, that people generally will consent to tests for the greater good of society.
Yeah.
Because the other side of it is if the person has a test, it's not going to lead to treatment because there is no treatment. It's only treatment of symptoms, which they could access without a diagnosis. So yes, you've got all these competing things. As an advocate, I'd be, making sure of being considered in that decision. But if in doubt, if you feel that it's going to have a negative impact, get legal advice and think, ask that question whether it should go to the Court of Protection to be decided.
Yeah, exactly. Right, let's move on. Issue 4. So this is really about coronavirus changing the relevant circumstances, which have to be taken into account in making a best interest decision. So this particularly concerns people who are deprived of their liberty under DOLS. And so one of the questions for you as an advocate is, what are you doing to think through the issues around risk of the person that you're supporting in the place that they are? Do you have the information about whether that care home, for example, has had an outbreak? Do you have information about how many people in that care home have been infected, whether the person you're supporting has been infected, and how that data feeds into a potential recalibration of the best interest calculation, such that for some people, it will no longer be in the person's best interest to remain in that particular setting because of the increased risk of contracting the infection, and of course the depending on the person, if they have have obesity, diabetes, respiratory issues, and so on, are they at risk because of those personal or medical characteristics? So the point here is that advocates have a role to cajole the local authority also in thinking through these issues. It'll be different in different parts of the country. It'll be different for different people in each care home. Right.
Yeah. Yeah. Peter Edwards, I think, made a comment as well around in mental health sessions, and I think the same can be made, the same arguments, and pushing for discharge or maybe extended Section 17 leave. That if there's an outbreak in that hospital, is that a safe place for people? And, I don't think we need to go in and demand people are released. It's about asking the question and putting that forward, isn't it? And seeing what the alternatives are. Should we go on to the next one? Yeah. Okay. So thinking about social care now. So moving away from mental capacity or mental health, thinking about Care Act. And we wanted to know whether local authorities in your area triggered the infamous easements, which are interestingly called. Yeah, easements. Very euphemistic, isn't it, for basically watering down, removing of relaxing the rights. Yeah. Okay, 55% of people have voted. Everyone has to vote because either the answer is yes, no, or I don't know. There basically can be no other answer. So we expect 100% attendance on this poll. Please. I've never seen you this bossy. It's I'm learning from you, Kate. 81, look at that. Give people a nudge, see? Ask very politely. All right. Okay, slow down. So I'm going to end the poll there. Share the results. That's interesting. 39% of people said, I don't know. What do you make of that, Kate? Not surprised. And we would be saying to people, make it your business to know. That one of the issues is that the local authorities that are triggering the easements are not making it easy. They're not being proactive in telling people, despite being arguably under duty to do that. They're not. This slide's just to confirm, because I'm sure if you've said you don't know, you might want to know whether you are in one of these 7 areas. So these are the 7 that have triggered. I don't think anybody's triggered in the last week either, so I think this is from the previous week. And just to mention that Derbyshire, there is actually a challenge. There was a pre-action letter, I think, sent to Derbyshire on the basis that they hadn't made the case, they hadn't provided information about how workforce depletion was actually impacting on their ability to deliver Care Act duties. So that was the bit, and I think they had until yesterday to actually respond. So I'm sure we'll know later in the week. But
people on the chat are asking about Wales, Scotland, and Northern Ireland.
Apologies. Yeah.
Yeah. All of a sudden, the whole of the UK, or rather, I'll say English people, are waking up to the fact that there are 4 nations, 4 jurisdictions in the UK, which, people didn't realise before.
Yes, and I've got to admit, I'm more focused on English, supporting English services in England, so I'm not sure is the honest answer. All right,
let's move on because we don't have much time, if that's all right, Kate.
Sure, yeah. So on the easements, just be checking this. If the local authority has triggered easements, it's probably going to impact assessments from the meetings, but they cannot use the easements to just arbitrarily reduce people's packages of care. We've had examples of people being written to say that direct payments are changing, reducing. We have had some examples where direct payments have increased because the local authorities recognised that they needed more flexibility. But the duty that, the local authority cannot legally change the person's care plan without doing a formal review process because they are revising. And the revisions under Section 27, I think, they are not touched by the easements, the Coronavirus Act at all. And that means that as an advocate, if you find out that a person's care plan has been changed without consultation and involvement of the individual, then that might give rise to a fairly straightforward legal challenge. And then the bottom point is we've had lots of anecdotal evidence of local authorities behaving as if the easements have been triggered, saying things like, oh, we don't need to do that because of COVID, or we no longer have a duty. Just be careful of that, because if it smells bullshitty, it probably is bullshitty.
That's certainly the experience of my colleagues in Chambers. I think that a lot of local authorities have just kind of slipped, have decided to ease their duties without triggering the easements. And as someone said on the chat, that list that Kate just had up a moment ago of the 7 local authorities, you can go on the CQC website at any point and see the up-to-date list. So that's from the CQC website, indeed. And again, someone else has made a point that interesting that most of those are from the West Midlands. Wonder why? Leave it there.
Oh, I don't know. But yeah, but it's noticeable it's on the CQC website and not DHSC. I think questions have been asked about why is that? Who's actually monitoring it? Okay, and then the last issue is advanced planning. We wanted to kind of acknowledge there's been lots of issues with do not attempt CPR. We're not going to go over that today because I think there's been a lot of attention given to that, and I would expect advocates to be full up to speed with rules on when to challenge that. But to sit that issue in the broader question of supporting people to make advanced decisions about treatment and care should they become ill. And this would be something I'd expect advocates to be used, experienced in doing. But we've heard anecdotally of GPs writing to people to say, should they become COVID-19 positive, they won't be taken to hospital. Or, they won't be taken to hospital in this scenario. Or again, groups, blanket letters saying people in the care home won't be taken. I don't know whether we want to do the poll now, but
yeah, absolutely. I think while that's going up, I think we messed up the numbering, Kate, because there is one more issue, which is care within care homes.
Oh, have I done the wrong one?
That's fine. Okay, so let's see how this is going. So essentially, the thing about DNA CPRs is that there was this massive confusion. It was ridiculous. Yeah. Just like so many other areas of public life, huge confusion until about 2 weeks ago with regard to people with learning disabilities, cerebral palsy, etc. Then it's been clarified that there should be no blanket, and there was this document with the NHS logo at the top that was floated around, and none of the NHS organisations claimed that they had written it. And so what was going on with that, no one knows. But essentially, these are clinical decisions, but there is an obligation to consult with the patient and potentially their family as well. And advocates can play a key role in facilitating that and making sure that really happens. So I'm going to end the poll there, share results. So most of you don't know, but those who do know say that, gosh, wow, 31% of people say that advanced decisions are not being made with the full involvement of the person. But I'm genuinely surprised. That's quite shocking, but interesting. Wow. Okay, should we scoot through the next one, Kate? Because people probably have other meetings.
Lives to lead. No, you're on this webinar forever.
Yeah, you're deprived of your Zoom liberty.
So thinking around issues within care homes, and again, we're hearing issues of difficulties in people being discharged from hospital to care homes. So care home managers refusing, for want of a better word, to accept people if they're COVID positive, or even if they're COVID negative. There was an advocate just yesterday saying that the person had a negative test, but the care home manager was saying, well, I want to wait for 2-3 days until the test, because they could have caught it in the period of time the test was waiting to come back, the results. So kind of lots of concerns. And of course, one might argue that care home managers are actually being quite reasonable and protecting the people currently living in that space. But then we've also heard of people who are being refused to actually return to their own homes. So they've lived in a place for a while, they've gone into hospital for whatever reason, they would like to go home, but the care home's saying no because they're COVID-19 positive. So I don't know whether people have got experience of similar issues, but yeah, we just wanted to raise that. And Oliver, I don't know if you wanted to say anything about the kind of the legal side of what could happen.
Yeah, I'm surprised that there aren't more legal challenges around what's happening in care homes, frankly. And there's some kind of chatter on Twitter, but I think that if advocates don't know what's happening in care homes, how are other people to know? So some of the issues are, well, what happens if someone's had 2 negative tests in a care home? Do they still have to be isolated? What does that only happen if there are people in the care home who have tested positive? What happens if there's a communal test and everyone tests negative and the staff all test negative as well? Does isolation still have to continue? I mean, isolation, if you think about it, if you have to be in your own room in the care home, or your own room in a mental health setting, these are sometimes quite oppressive places. What adjustments are being made to facilitate people going for a walk in the garden or to sit in the communal lounge, socially distanced from other people? Is isolation in a care home bedroom really necessary in all circumstances? And one of the things I've been very critical about publicly is the horrific guidance, or horrifically unclear and unhelpful, in my view, guidance from the Department of Health and Social Care about care homes in England. And hilariously, at the weekend, the Scottish government put up on their website much better guidance. And I spent several hours analysing that and tweeting about it. And then on Sunday early evening, the minister in Scotland said, oh, oops. She took it down from the website and said, oh, that was just a draft without clinical or political sign-off. So I was saying how much better the Scottish guidance was and how it shows up the English guidance to be really unclear. And then Scotland took down its own guidance. Anyway, so I think that if I were working in a care home, if I were a care home manager or a care home staff member, I would be utterly confused about what it is that I'm supposed to do with regard to PPE, isolation, a whole range of different issues. So this is something that I think needs way, better clarity and direction from government. And I feel so sorry for people working and living in care homes.
Yeah. And of course, that's where advocates can play a very helpful part in asking those questions. So yeah, there's no list of rights and wrong. Well, there are in law, I know, but in this context, does somebody have a legal right to go outside? And if they've got COVID-19, it's about asking that question, isn't it, and pushing for why not. And as advocates, when the answer's reasonable or when the eyebrows disappear around the back of your head. And if it doesn't feel right, then keep pushing until you get an answer, particularly for your partner, that feels acceptable. And if that, go and get your legal colleagues in, like Oliver, who can then use the weight of the law, or give advice, if it is particularly difficult. And I'm mindful that it was a very extreme case where a gentleman in a mental health hospital was COVID-19 positive. So they segregated him in his room. He didn't have ensuite facilities, so that they were passing him a bedpan. And this is kind of roughly at the same time, full bedpan, his food was being passed. He wasn't allowed out for exercise. He, was just stuck in this room because he was COVID-19. And the IMHA was there pushing just for access to his own bathroom. And really concerned about the dignity and how unpleasant that was, and successfully got him moved, had access to a toilet then. But
so
things
Kate,
like
I don't know whether you can just flick to the final slide so people can have contact details. Tash, in the chat, this is a really good point I think you've raised, who said that it can be difficult to challenge what's happening in care homes in an environment when we are nationally treating the health and social care field as a whole as heroes. So that prevailing discourse as heroes, and we're all clapping once a week, etc. That's really interesting, right? Because that's one set of discourse. Then another set is what's actually happening. And we know that just like in all professions, there is a variety of talent and professionalism in the social care sector. And still advocates and the CQC, etc., have a really key role to play in holding the care home sector to account and ensuring that people are receiving effective and safe and humane services. So
and I think most advocates have not been, we have been fairly respectful, I think, of the crisis and the impact it's going to have on services abilities. I don't think anybody is demanding that things return to normal, because that would be foolish. But yes, you're right. There's a line, isn't there, where we are that backstop, and if you're concerned, if you're concerned, then that's where you push. That's where you push it good.
Absolutely. Well, there we are. That went very quickly, at least for me. Shall we draw to a close?
Yeah, unless there's any burning questions that people, I'm not, in a rush to dive off, unless you've got commitment, Oliver. But I know people have Zoom fatigue, but if they've got specific questions, do you want 5 minutes?
Yeah, so let's bring it to an end. I can see people dropping off, as it were.
Okay.
And so if you want to stay, if there's any particular point that you want to discuss in the chat room, then stay. We'll stay for another 10 minutes, but let's draw this, the formal part to a close. There's been over 300 people. Thank you very much for joining. And let us know if you want us to hold another one of these webinars. Give us feedback.